So, one of the first things that we think about um, when we experience some sort of intense sensation is pain, and so we say, "Ouch, that hurts." That's painful, and yet understanding that um, what pain actually is um, can be very important from my perspective in terms of looking at the treatments of pain. And so the International Association for the Study of Pain, the International Association for the Study of Pain, came out with a definition. I believe it was like maybe in the 70s or 80s or something like that, on what pain actually was or is. And what their definition was a pretty it was a pretty good definition, pretty basic, but it was an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And so we've gone through that definition before. An unpleasant sensory and emotional experience associated with actual or potential tissue damage. So again, just from that one-liner, right? First of all, it's an unpleasant sensory and emotional experience. So again, taking into account the sensory input is really the transmission of information from the periphery to the central nervous system, right? And it comes from the sensory nerves, and it gives certain information to the brain. But there's also an emotional componentry of that. So we can't separate the sensation, the sensory aspect, from the emotional aspect when we're looking at pain. Many of us do, but we really shouldn't. Looking at a holistic approach to pain. The other part of that definition that I kind of latch onto a bit is that it's an experience, and experience is a very interesting word that they would use, right? Why? Because an experience is so individual. It's so unique. It's so personal, right? It's like we can be walking down the street and seeing the same cars coming at us, seeing the same, people walking by, seeing the same stores, seeing the same animals, dogs, pets, whatever, walking by us. And we're having completely different experiences, right? Walking down the street. And so my sort of interest is how is that experience created? Right? We have some sort of sensory input that's coming in. We have an emotional input that's coming in, and it's an experience. It's a very personal, it's a very unique experience. And more likely than not, it's based on the wiring of our brain and the processing of this information that's coming in, that then comes in, creates an experience, and that's our experience in that moment. Okay. And then it's associated with actual or potential tissue damage. Well, we've talked about that, right? We've talked about the potential tissue damage. You hold your hand over a burning flame. Your hand doesn't burn, but you feel the heat. You describe it as pain. Although if you just look at it from the sensory component, maybe it feels sharp, stabbing, whatever it might be. You pull your finger away, you don't burn your finger, you don't even burn your skin. Your tissue is not damaged, but yet you actually moved your finger away prior to the tissue damage actually occurred. Okay, so it's actual or potential tissue damage. Well, with all the research that has come out in chronic pain and all the fMRI imaging and EEG imaging, in 2020, they actually decided to change to add on to their definition, let's say. Okay, so let's just kind of look at some of the additions that they added. The International Association for the Study of Pain, the revised definition in 2020. An unpleasant sensory and emotional experience, so they still have that, associated with or resembling that associated with actual or potential tissue damage. To me, that's an interesting addition. Or resembling that associated with. Right, what does that mean? Well, it looks like something that should be causing pain, and so therefore, so they still have the sensory and emotional experience, right? They still have the sensory and emotional experience associated with, or resembling that associated with. So it can resemble that which is associated with actual or potential tissue damage. Well, that's interesting. Okay. Now, this is not just like one person who sits behind a desk and doesn't see. This is a multidisciplinary group of clinicians, therapists, practitioners from all different walks of life that are on these committees that come up with this definition, right? And what's interesting from that definition is now there's a resembling, right? So if something resembles, if there's a resemblance of possible tissue damage or potential tissue damage or even actual tissue damage, that you may still have the experience of pain. And this is actually comes from some really good research that they've done, essentially, tricking people in making them feel pain without actually giving them a painful stimulus or an unpleasant stimulus. Okay, and there's a number of research papers that kind of go into this. Of you're made to believe that, let's say, a band around your head is constricting, and guess what? Most people will report if they are made to believe that a band around their head is constricting. They start to get head pressure and head pain, even though there's the sound of a constriction. Maybe there's a slight like tingling or vibration, but no actual constriction. Okay. And what the sensory input that you're getting, wherever it's coming from, right, is actually that of constriction, and you're feeling like the pressure in your head is building, and you report it as a headache, even though there's no actual compression. There's no unpleasant sensory experience, but there's a resemblance of it, and so therefore your experience is that it's absolutely true. It's absolutely happening. Okay. There's a really famous case study that was published in the British Medical Journal, I believe, and then subsequently published in other journals of a construction worker who had a nail going through his boot, and you may have seen this picture. It was actually written about in Psychology Today, I believe, even 1 or 2 years ago. And we may have discussed it here in the past as well. But the nail is going through the boot, right? And you see it. They take a picture of the boot, and the nail's going through it. And it's actually a steel toe boot. You can actually see on the picture, you can see the steel toe. And the nail going through it. And, the person was in severe pain, 10 out of 10 pain, worst pain of his life. They had to take him to the emergency room and give him real strong pain medications before they could actually control the pain, sedate him, and be able to remove the nail, to remove the boot, and they were getting ready to go in to fix this injury, right? And as some of you may know, the nail completely missed his toes. It went in between his digits like this. It missed the steel toe because the steel toe came and sort of protected this area, but it went right in between his digits. So he stepped on it, boom, it went right through. And he had no tissue damage whatsoever. None, zero. Right? But his mind sees this nail, right? And that's that part of that definition that I think they're kind of adding on to it, which is resembling that associated with actual or potential tissue damage. Okay, so here's something that resembles something that would likely cause tissue damage. And what is that person's experience? Pain that requires pain medication to decrease, right? So that they can take out the nail, take off the boot, they're ready to repair it, and they see, there's nothing going on. Okay. Well, the question there is, was that individual's pain real? And the answer is, of course it was real. It was absolutely real. Why? Because that was the patient's experience. Okay. And that's what makes pain, in my opinion, such a fascinating topic, because it's very subjective. It's very unique. Right now, I still can't take a monitor and put it on you and say, oh, you're in 10 out of 10 pain, or you're in 4 out of 10 pain. Even though we tried to ascribe a vital sign to pain and call it the 6th vital, okay, that was the only vital that I actually had to talk to you about. Every single other vital was what we call an objective data point, which is given to me by a monitor that I don't actually need to communicate with you about. I can get your blood pressure by putting a blood pressure cuff on you and getting a blood pressure. In fact, you can be unconscious and I can get a blood pressure reading if you have a blood pressure. Heart rate, same thing. I don't have to ask you. You might know your range, but you probably don't know what your heart rate is right now. Maybe it's 66, 72, whatever it might be, right? But what do? Well, you put your hand on your radial artery, your carotid pulse, and you go 1, 2, 3, and you time it, right? Okay, 60 beats a minute. Great, that's where I am right now. Okay, but I don't need to talk to you. Some people like that. Hey, let's get all the information for the patient without talking about it. Other people actually like the subjectivity of it. Okay, temperature, right? You stick a thermometer in the mouth, or wherever you want to get it. Okay. Respiratory rate. Are you breathing? I watch you. I don't ask you. I watch you. I watch you breathe. How many times? Sometimes it's like you put your hand on their shoulder or on their rib cage, and you feel the chest. Okay, 12 breaths a minute. Right? Temperature. O2 sat. Those are the five vitals, right? Oxygen saturation. Hopefully you're above 95%, but in order to know it actually, you put a monitor on and you don't question it, right? It's like, oh, I'm 96%. If it's totally off, right? If it's like, well, that number doesn't make sense, then you question it, right? So like, oh, that blood pressure reading came back as like 10/5, but here I am talking, that just doesn't make sense. Let's repeat that, right? But then you get a different monitor, you get a different blood pressure cuff, whatever it might be, you repeat it and you get the number. If it's all working, we're pretty satisfied with those numbers, okay? With pain, we added that on as a vital. And that's a number that I need to ask you. What's your pain level? Okay? It's a subjective. It's an experience. It's not an actual objective data point. Maybe we'll get to that point where I can scan your brain and say, oh, you're having pain in your right hip. That's 8 out of 10. And because it's this bright, I know it's 8 out of 10. And if it was a little bright, if it was a little less bright, it'd be 6 out of 10. But if it was more bright, it'd be 10 out of 10. Right? Maybe we'll get to that point. Or we see this emotional part of the brain that's active. So therefore, it must be 10 out of 10 because your emotional componentry of the brain has been now activated. And so we know that that's going to activate your pain. So I can tell you that your experience is this based on this scan. We might get there, but we're not there yet. Okay. So it's very subjective, right? You actually need to have a conversation with somebody. I don't know if you're having a headache right now, or if you're having right knee pain, or if it's left foot pain, or if it's back pain. Maybe people kind of move around with back pain, but that could be hip pain. Okay, or it could be lower thigh pain sometimes, right? My point is that it's very subjective. It's very experiential based. Okay. Some of the other definitions that I liked, especially when I was going through my specialty is physical medicine rehabilitation, and some of the other definitions that I liked that I found along the way is from a nurse. She's a pioneer in the field of pain management. Her name is Margot McCaffrey. Pain is whatever the experiencing person says it is, existing whenever and wherever the person says it does. I mean, how much more subjective can you make? Right? Pain is exactly what you tell me it is. Like, that's part of the beauty of it, right? What is your pain? How does it feel? Where is it? How is it located? Well, it is whatever the experiencing person says it is, existing whenever and wherever the person says it does. Perfect, right? Nobody can argue with you. From the fourth edition of the Bradham Principles of Physical Medicine and Rehabilitation, pain is a subjective and entirely individual personal experience influenced by learning, context, and multiple psychosocial variables. Pain is a subjective and entirely individual personal experience influenced by learning, context, and multiple psychosocial variables. That also very, very subjective, right? Influenced by multiple psychosocial variables, culture, context, so many variables that are actually affecting what? Our experience. Right? Not whether or not the tissue is damaged. The tissue can be damaged, but our experience of the damaged tissue as our brain is processing it. All right. Now, in 2020, like I said, the International Association of the Study of Pain added on this component of the definition and brought in this, resembling that associated with, but it expanded upon 6 key notes for further context. So they said, hey, look, based on everything we've learned about chronic pain, we need to even add more onto this definition. And we're gonna add these 6 key notes to it. Okay. And what are those key notes? So the first one is pain is always a personal experience that is influenced by that is influenced to varying degrees by biological, psychological, and social factors. Pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Okay? Ladies and gentlemen, if we're not looking at the psychological and social factors of pain and the subjectivity of the experience, we're not looking at pain as a whole. Okay? We clearly know now from the data how much the psychological and the social aspects actually affect our experience and how individualized that actually is. Okay. Pain and nociceptions are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Well, we've been talking about that a lot. Okay. The nociception is that transmission of, let's say, a chemical, right? A burn, we have mechanical nociceptors that are activated by sheer stress and movement. We have temperature nociceptors that are activated by high and low temperatures. Okay, we have chemical nociceptors. Those are receptors on the neurons that are triggered when that chemical or when that activity is taking place at the periphery, and then it sends a signal. Right? When you touch something, when my fingers are touching, those touch receptors are being activated, sending a stimulus to my spinal cord, going up to my brain, saying, oh, my right index finger is touching my left index finger. And it has this amount of pressure on it. Right? If I went more, I would feel more pressure because those receptors are being activated more. That's nociception. Okay, then there's the transmission of the information. There's the transmission of the nociception through the sensory nerves. Then those sensory nerves go into the spinal cord. The spinal cord goes into the thalamus, which is the major relay hub in the center of the brain for all sensory input. And then that gets dispersed to all the areas of the brain that, guess what? Well, they perceive the nociception, but they also are interpreting this experience with emotions, context, safety, danger, right? All these sorts of things that what's the environment? Who are you with? Okay. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory nerves. So even though you might have sensory nerves that are active, that doesn't necessarily mean that your pain experience is going to be so high, so bad. Oh yeah, right. You've heard those. You may have even had it yourself. Oh yeah, it's really burning, but I'm okay, doing all right, right? As opposed to sometimes where it's like, wow, I don't see anything, but it's like, oh my god, the pain. Ah! Okay. Very different pain experiences. Right? You see the nerve damage or you see the tissue damage. You know that those nerves are active. That's the nociception coming in, but your experience of that is, oh, we're cool. Okay. Throughout their life experiences, individuals learn the concept of pain. That's interesting. We've talked about that in kids, right? What's the sensory input? Well, you look at they're running, they scrape their hands. The sensory input, that's that nociception, right? Ah, yes, that's an unpleasant sensory experience. Okay, and what are we trying to do? Make them feel safe, right? We're taking that evolutionarily kind of programmed danger signal that the brain is interpreting and actually trying to make them feel safe. And using all the mechanisms that we know from being a good parent or caretaker or just a human being of saying, hey, let's wash it, let's put a little Band-Aid on it, let's kiss it, let's make it feel good, right? And what's happening to their experience is actually it's shifting in real time. Or you're distracting them. You're looking at the birds, you're finding an airplane, you're giving them a lollipop, you're getting their favorite candy or ice cream, whatever it might be. Okay. And that this pain is actually a learned response, can actually be a learned response, right? Throughout their life experiences, individuals learn the concept of pain. A patient's report of an experience of pain should be respected. Wow, where does that come from? Right? I don't believe their pain. Right? They're making it all up. They're making it all up. Okay. Well, what's your experience? My experience is this pain. Okay. Well, then whether or not there's a nociceptive signal, whether or not there's an unpleasant sensory signal, just like the person who had the nail going through his shoe, that person was experiencing severe pain. Okay. Now, surgery wasn't the appropriate treatment, right? In fact, they didn't do surgery. Okay. So just because somebody's feeling pain or experiencing it does not mean that, oh, we're going to do, this is how you treat pain. You go from medications to injections to surgery, right? That person was experiencing pain. Surgery was not the right treatment. They weren't offered surgery. They weren't even offered an injection, right? As soon as they found that there was no tissue damage, they had a conversation with the patient, right? It was an education. Okay. So a person's report of an experience as pain should be respected. Although pain usually serves an adaptive role, and that's where we're talking about in especially acute pain, right? We've talked about that. An adaptive makes you change what you're doing, makes you protect yourself, helps with your survival. Maybe it changes. Oh, that's the bush that has those really good berries, but every time I go into it, I get poked by the thorns. Okay, so I got to be careful or wear protective gloves, right? So I don't get irritated by the thorns. Okay, so it does have serves an adaptive role. It may have adverse effects on function and social and psychological well-being. And that's mostly talking about chronic pain. They're not differentiating here chronic from acute pain. But we've talked about those differences, right? We've talked about the differences of the acute pain having this adaptive role, making us change what we're doing, helping us out, right? Maybe we need to strengthen that muscle or joint, or next time we don't put our hand on the burning stove. Okay, so there's a very good adaptive mechanism here. In chronic pain, though, when we've ruled out anything that's dangerous or harmful, it no longer serves an adaptive mechanism. So we want to strengthen the muscles. We want to move. We want to decrease our stress. We want to really shift that signal from the danger to the safe, danger to the safe, danger to the safe, danger to the okay, harmful to the okay, harmful to the okay. Okay. If it's that chronic pain that we know, it's sort of like, it's lingering, kind of that, there it is. Okay. Verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. And this took a little bit of time to actually, develop. But people were, I remember being in the ICU and being like, that patient might be in pain, even though they're intubated and unconscious. We're looking at their heart rate, right? Do they have an infection? We need to look at if their heart rate all of a sudden elevates. Is that a sign that they are in pain? Or is that a sign of something else? Are they dehydrated? Have they gone into shock? Or do they have an infection or something like that? But pain needs to be sort of assessed. So again, just because somebody might be nonverbal does not mean that they don't experience pain. And I may have told you guys before that when I did my rotation, my pediatric rotation at Children's Hospital in Boston, it was in 2008 or 2009. And there were signs in Children's Hospital Boston. This was, part of the medical, part of the Harvard Medical School hospital systems. And it said, sort of like new research shows that infants can feel pain. Okay. And to look for signs, look for those nonverbal signs of pain or even verbal signs of pain, because in an infant, crying, right, could be a big sign that they're in pain, and we're not making sure about it, right? But big signs. New research shows that infants feel pain, right? Because there was actually a thought, there was actually a practice that believed that infants did not feel pain because their nervous system wasn't fully developed and stuff like that. All right. So that's so you can see how these changes to the definition. 6 key steps here. Pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Really looking at those psychological and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Through their life experiences, individuals learn the concept of pain. A person's report of an experience as pain should be respected. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. Verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or non-human animal experiences pain. Right? Really, 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 really important from my perspective to kind of have a good understanding of that definition. Why? Because if you're in pain management, if you're doing anything related to pain management, okay, and we're only focused on one of those aspects, the biological aspect, which is probably the aspect that many of us have been sort of focused on the most, is, oh, this is the biological aspect of pain, right? With medications, injections, surgeries, even things like bracing and therapies. Right? That's all the biological aspect. We're trying to strengthen the joints. We're trying to loosen the tissues, or whatever it might be. We're trying to medicate. We're trying to palliate the symptoms. We're trying to inject. Hopefully, we can cause some sort of maybe tissue regeneration with some of the new regenerative therapies. We're trying to decrease inflammation. We're trying to repair any damaged tissues with surgery, et cetera, et cetera. We focused on that. Right? But what we haven't really looked at is even the initial part of that definition, the sensory component. We're really trying to decrease the sensory component, but we have very little on the emotional component, on the psychological or social component of pain. All right. So kind of understanding that and being like, oh, well, again, there's this sensory input that is coming to my spinal cord, that's going up to my brain, and how that signal is transmitted is going to affect how I interpret the signal, how my brain is wired, and all of my past experiences are going to interpret that signal. Okay, are going to influence the interpretation of the signal that's coming in. What's the context of the injury or the pain I'm feeling? Do I feel safe or do I feel endangered? Okay, what are the incentives behind being injured or not? All of that and more. Did I sleep last night? Do I have a baseline of anxiety, panic, PTSD from something that happened to me when I was 5? All of that comes together in terms of all the wiring that has occurred in the brain. And here's this sensory input coming into your massive quantum supercomputer. And guess what? You with all that, you spit out this experience. Pew. Oh, here's my experience. Oh, wow. Okay. So with all these practices that we've been talking about, looking at shifting from danger to safety, looking at balancing our sympathetic and our parasympathetic nervous system, looking at causing our stress response to decrease, to not be so wired to always be on high alert, right? Practicing mindfulness, where we're able to look at the sensory input that's coming in, the thought input that's coming in, the emotional input that's coming in, seeing if we can just see it as that, as just a cloud that's passing in the sky and not identifying with it. Seeing if we can separate the sensation of the nociception, of the sensory nerve that's sending a signal to my brain that's interpreting it as pain from the interpretation, right? All the things that we've done. What's the sound that I'm hearing? Oh, that's a garbage truck. Okay. How quick is that interpretation? As opposed to, can I just describe the sound? Right? Similar practices, though, in different contexts, help us kind of unravel, right? Unravel, let's say, maybe some of our past experiences, maybe some of the way that we've processed past experiences, be able to be more in the present moment with paying attention to our breath, repeating a mantra, watching a flower, right? Feeling our feet on the ground, whatever it is that your anchor or resource is. And slowly, slowly starting to rewire your brain to be more balanced, to be less on high alert, so that when a signal does come from the nociceptors, that might be an appropriate signal of, hey, you just put your hand on a stove, you can actually pull your hand off the stove and say, oh, let me take care of it, without having all the other componentry sort of jumbled on top, and then accentuating the experience beyond that which it may be necessary. This to me is very important because I think it's one of the frameworks for chronic pain management. I really do. I really think that kind of like really understanding the definition. Wow, I'm in pain. Okay, well, what does that mean? Well, I had this elbow injury and I had this surgery, and it just it's like this. Okay, well, let's unravel that. Right? There's a sensory input that's coming up. There's the chronicity of that stimulus. There's the stimulus on the nerves of the brain itself that are creating a memory. And that memory is based on past experiences, emotions, et cetera, et cetera.